Hi everyone, my name is Pavel Antiporovich. I am a Canadian cardiologist currently completing training in cardiac electrophysiology. Today we'll be discussing a foolproof approach to SVT diagnosis on single lead tracings. This is a two-part video. In part one, we'll be building an approach to formulating a differential diagnosis and discussing the mechanisms of arrhythmia. And in part two, we'll apply the learned concepts to a series of tracings. Ever since I was a medical student, I found that interpreting SVTs to be one of the most frustrating concepts in ECG interpretation. It wasn't until I became an EP fellow that I was taught a very straightforward and logical approach, which made ECG interpretation quite fun. To master this, I had to unlearn my previous techniques, which were based on published algorithms and pattern recognition. In this video, I'm going to introduce you to this approach. First, we will review the basics of conduction, particularly what makes the QRS wide and what makes it narrow. Then we will discuss formulating the differential diagnosis, which is the key to this approach. Then we will discuss the mechanisms of arrhythmia for each item on our differential diagnosis, and then we'll apply these concepts to a series of tracings and assess the onset, the SVT itself, as well as the termination to rule in and rule out certain items on our differential diagnosis list. This is a simplified diagram of the cardiac conduction system. It is composed of the AV node, the common bundle of His, the bundle branches, the fascicles, and the Purkinje fibers, which are not shown in this diagram. The word supraventricular refers to an arrhythmia where the key mechanism is above the bundle of His. These arrhythmias use the His-Purkinje conduction system to activate both ventricles quickly, which creates a QRS that in most cases resembles the baseline QRS. If the baseline QRS is narrow, it will often be a narrow complex tachycardia, barring any rate-related bundle branch blocks. Now, it's important to note the AV node serves as a gateway into the ventricles, and a large portion of the population has more than one pathway within the AV node. One pathway generally has a relatively slower conduction compared to the other, and the faster pathway has a longer refractory period, meaning that it takes longer to recover than the slow pathway. In individuals with more than one pathway within the AV node, what we call dual AV nodal physiology, conduction during sinus rhythm generally takes place down the fast pathway. The slow pathway is often engaged, but by the time the signal reaches the common pathway, it's already depolarized, and the slow pathway is of no consequence, and the person continues to live free from arrhythmia. In a subset of patients with dual AV node physiology, the conduction properties of the pathways are such that an arrhythmia can occur. Consider a PAC that activates the atrium prematurely. The signal is first blocked in the fast pathway, which has a longer refractory period than the slow pathway and takes longer to recover. Yet the signal can enter the slow pathway and proceed its way to the common pathway. By the time it reaches the common pathway, the fast pathway has now recovered, and it can come back up the now recovered fast pathway and re-enter the slow pathway again to reactivate that tissue. This forms a macro reentry circuit that's entirely contained within the compact AV node. This is called typical AVNRT. This diagram illustrates the three basic requirements of a macro reentry circuit. There has to be slow conduction, a unidirectional block, and recovery of the tissue, allowing it to be re-excited. When assessing a tracing for an SVT, it's important to formulate a differential diagnosis list. The differential diagnosis for SVT can be quite long. EP physicians generally group them into four main categories which have distinct properties. Let's go through each of them and discuss them in more detail, starting first with atrial tachycardia. An atrial tachycardia is an SVT where the mechanism is located entirely within the atrium. Examples of this include sinus tachycardia, which originates in the crista terminalis in the superior right atrium. Atrial flutter, which is a macro reentry circuit that involves the cavo-tricuspid isthmus, which is the space between the tricuspid annulus and the IVC, focal atrial tachycardia, which is illustrated in this diagram, and sinoatrial reentry tachycardia, which is a form of sinus tachycardia. I want to take a moment to talk about terminology. This was confusing to me as a learner. Mechanistically, many electrophysiologists group all arrhythmias with a circuit entirely contained within the atria as atrial tachycardia. This includes any macro reentry circuits such as atrial flutter and focal mechanisms such as focal atrial tachycardia. However, it is nearly impossible to be sure of the mechanism by looking at a 12-lead tracing. Hence, in practice, many clinicians use the rate-based definition. If the atrial rate is greater than 250 beats a minute, they call it flutter. If the atrial rate is less than 250 beats a minute, they call atrial tachycardia. Obviously, a common macro reentry circuit is the one illustrated here. It uses the caval tricuspid isthmus as a turnaround point for the arrhythmia here. This one most clinicians should be able to identify and have relative certainty about the mechanism. For the purposes of this presentation, I will use the mechanistic definition and refer to all arrhythmias contained entirely within the atria as atrial tachycardias. Next, we will discuss AV node reentry tachycardia. The mechanism of this arrhythmia is situated entirely within the AV node, which on this diagram is indicated by this green structure here. Notice that this does not require the activation of the ventricles or the atria to sustain itself. Occasionally you will see an SVT on a tracing that seems to be missing a P wave or the QRS but continues uninterrupted. This could very well be AVNRT with a block to the ventricles or the atria for one beat, but because the tachycardia does not require either of the two chambers, it continues uninterrupted. The key feature of typical AVNRT is the simultaneous activation of the atria and the ventricles. When a signal goes down the slow pathway, it reaches a common pathway and bifurcates. One signal goes down to the ventricles to activate the ventricles and make a QRS, while the other signal comes up the fast pathway and can enter the atrium. This process takes place simultaneously, and on the ECG, it can be illustrated by finding P waves and the QRSs that are overlapped. This is an example of typical AVNRT initiation. It initiates with a premature atrial contraction, much like it did in the example we were discussing initiation of macro reentry arrhythmias earlier in this presentation. This premature atrial contraction is followed by a long PR interval, which represents slow pathway conduction. After this, you see a QRS and a P wave that are overlapped, and the SVT continues with the P on QRS fashion. Looking at this QRS, I know that there's a P wave in it because I can compare it to the sinus QRS and T wave. If I template the sinus QRS and T wave, I know that there is a high frequency deflection in the tail end of this QRS, which was not there previously. This likely represents a buried P wave. It is important to note that P waves cannot be seen quite often in typical AVNRT because they're often buried deep in the QRS. However, simultaneous P and QRS are quite characteristic of typical AVNRT. Other forms of AVNRT are the atypical forms. This includes the fast-slow variety of AVNRT, where there's an anterograde fast pathway and a retrograde slow pathway, basically the opposite circuit to what is shown here. There's also the so-called slow-slow variety, where both pathways indicate slow conduction. It is important to note that it is often difficult to diagnose atypical AVNRT on our surface tracing and distinguish it from the other differential diagnoses, because the P wave is often located in different parts of the cardiac cycle, depending on the patient's conduction properties in each pathway. The third item on the differential diagnosis of SVT is atrioventricular reentrant tachycardia AVRT. This is a large macro reentry circuit involving the AV node, the bundle of His, the bundle branch block that's ipsilateral to the accessory pathway, oftentimes the fascicle, the myocardium that's close to the accessory pathway itself, and the atrial myocardium. Now, the key property of AVRT is that it requires both the atria and the ventricles to sustain the tachycardia because they're part of the circuit. If the patient develops a conduction block in any of these structures, the tachycardia circuit will either terminate or it will bypass the block and the tachycardia circuit will change. A famous example of this is the sudden development of a left bundle branch block during the tachycardia. If it occurs, the opposite left bundle branch block will become part of the circuit, and the conduction will happen transeptally to the left ventricle and back up the accessory pathway. This would create a much larger tachycardia circuit, which may often slow the tachycardia cycle length, and the VA time will prolong. There are two types of AVRT. There's orthodromic and antidromic. Orthodromic AVRT is far more common, and this is the one that is demonstrated in this example where the AV node is anterograde and the retrograde limb is the accessory pathway. This is much more common than the opposite scenario because most accessory pathways can only conduct retrogradely. Now, antidromic AVRT is characterized by the accessory pathway being the anterograde limb and the AV node being the retrograde limb. And these are often or almost always wide complex tachycardias because the accessory pathway usually inserts directly into the myocardium and does not use the His-Purkinje system of the ventricles to create a narrow QRS. Hence, the QRS is usually wide, maximally pre-excited, and usually not included in a differential of a narrow complex tachycardia. It is important to note that there are multiple types of accessory pathways, and some insert directly into different parts of the conduction system, and discussing these pathways are outside the scope of this talk. Last but not least is junctional tachycardia. JT is a focal tachycardia within the AV junction. It does not require the atrium or the ventricles as part of its mechanism. With each JT cycle, there's a retrograde component that conducts to the atria to generate a retrograde P wave, and there's an antegrade component that comes down to the ventricles using the His-Purkinje system to create a QRS of supraventricular morphology. Conduction to the atria and the ventricles occurs simultaneously in JT. So this is usually a P on QRS tachycardia where the P wave is buried within or in the terminal portion of the QRS. That's very difficult to distinguish from AVNRT due to its very short VA time. To summarize, in this video we briefly reviewed the cardiac conduction system, developed an approach to formulating a differential diagnosis, and discussed the mechanisms of arrhythmia. In part 2, we'll apply these concepts to a series of tracings and become familiar with a number of features that will narrow the differential diagnosis.